Good morning. Today we're going to talk about blood. In particular, we're going to go over some basics of transfusion medicine. We're going to talk about some of the blood products available to us, and we're going to talk about the indications for their use. We'll also talk about some complications that we may see, and we'll finish up by talking about possible alternatives to transfusion. The ability to safely transfuse blood from a donor to a patient has to be considered one of the great achievements of modern medicine. This ability has allowed us to do very complicated and difficult operations and has allowed us to save innumerable injured patients. The basis of this ability to safely transfuse blood is the understanding about blood groups and the understanding that a donor and a patient have to have the same blood group for the transfusion to be compatible. And this brings up also the issue of compatibility testing. Ways had to be developed to know that, in fact, the donor and the intended patient had the same blood types. Red blood cells carry surface antigens for at least 30 different blood groups. But as it turns out, only the ABO and RH groups are clinically important. All the rest of the groups are lumped together and considered as minor transfusion antigens and only rarely cause us a clinical problem. White cells and platelets do not carry the ABO and RH antigens. White blood cells only carry HLA antigens, and platelets only carry HLA and platelet-associated antigens. When blood is typed and cross-matched, it's only for these red blood cell antigens. Now, when you transfuse a unit of red cells, oftentimes some incidentally transfused white cells and platelets will come along, but this is usually well tolerated. Occasionally, these cell types can be responsible for febrile reactions and allergic reactions, which we'll talk about in a little bit. The ABO blood group consists of 4 different types. In the United States, 47% of people are type O and 41% are type A. The rest are either B or AB. Now we inherit 2 codominant alleles, and each of these alleles produce an enzyme that goes towards constructing an A or B carbohydrate structure on red cells. And I would say parenthetically on endothelial cells as well. And this is why correct ABO matching is imperative in the transplant world, along with HLA matching. Now, people who are group O, they have 2 alleles that produce an inactive protein. So in other words, they're unable to construct either an A or B carbohydrate structure. The ABO carbohydrate structures are highly immunogenic. In fact, these antigens are ubiquitous throughout nature, and so we are born pre-sensitized to the antigen that we lack. In other words, if an individual is blood type A, they will have strong IgM antibodies against the B antigen, and vice versa. These IgM antibodies cause the immediate fixation of complement, and so you end up with an immediate hemolytic reaction and the release of free hemoglobin into the circulation. And as we'll see in a bit, it's the release of this free hemoglobin that causes all the problems in a transfusion reaction. Now, since blood group O is antigenically weak, since it doesn't have the carbohydrate structures on its surface, as it turns out, most people can accept blood from a group O donor. The other major blood group system is the Rh system, and this refers to the presence or absence of the D red blood cell antigen. In the US, about 15% of people are Rh negative, or in other words, they lack this D antigen. Now, the Rh system works fundamentally differently than the ABO system. Rh negative people are not born with strong preformed antibodies to this D antigen. And so a prior exposure event is required to pre-sensitize an individual. The two most common ways this could happen would be transfusion. In other words, you transfuse Rh positive blood to an Rh negative person, and you do this the first time when they're not pre-sensitized. The second way this can happen is through pregnancy, where an Rh negative mother is carrying an Rh positive fetus. Now, once you are pre-sensitized, an Rh positive transfusion will cause an immediate hemolytic reaction. By far, the most feared complication of Rh incompatibilities is hemolytic disease of the newborn. In this situation, an Rh negative mother has been pre-sensitized, and she's now carrying an Rh positive baby. Her anti-D antibodies can then cross the placenta and destroy her baby's red blood cells. Fortunately, we can prevent these sensitization events in almost all cases, and it's standard of care nowadays for an Rh negative pregnant woman who's bearing an Rh positive baby to get Rh immune globulin. Now, this comes up for us as surgeons because we take care of pregnant trauma patients. And a pregnant woman who's undergone a significant trauma, especially a significant abdominal trauma, may well get sensitized from this trauma. And so giving Rh immune globulin is part of the care of significant trauma in pregnancy. Let's mention a few words about compatibility testing. This is the process that the blood bank goes through to make sure that the donor unit of blood is safe to give to the intended patient. There's two different ways compatibility testing can be done. The first is the type and screen method. When you order a type and screen, you're asking the blood bank to do the ABO and the Rh typing. In addition, they will screen for a multitude of non-ABO antibodies. These are the minor antigens we talked about earlier. And lastly, they will check their records to see if there were problems with any previous transfusions. Blood banks in general keep meticulous records, and so they always check before they release any blood. Now, the final step that has to be undergone before the patient can get the blood is the cross-matching. In this situation, the blood bank takes a small amount of the patient's serum and actually mixes it with a small amount of the intended red blood cell unit, and they're looking for any surprise hemolytic reactions. If there are none, then the blood can be released to the patient. It's important to note that when you order a type and cross match, what you're doing is figuratively taking blood off the shelf that can only be used for one specific patient. So you should only order a type and cross when it's highly likely that the patient will be transfused. If you just want to be safe and get the process started, but you don't think a transfusion is terribly likely, then a type and screen is often appropriate. The full type and cross-matching process can take anywhere from 30 to 60 minutes, depending on your blood bank's efficiency. Since it can take upwards of an hour to fully type and cross-match a patient, we will need a strategy to how to deal with a patient who requires an emergency transfusion. This will most commonly occur in a trauma patient, although it could also occur in a massive GI bleeder as well. Our strategy will be, in almost every case, to give these patients uncross-matched type O Rh negative blood. This is safe, this is effective, and it's generally widely available. If for some reason there were no type O Rh negative blood, there's a couple of other strategies one could do, but the use cases here would be extremely limited. You could consider type-specific blood. This is patients who've had their blood ABO and Rh matched, but the blood hasn't undergone the final cross-match or antibody screen. And so there is about a 1% risk of a significant hemolytic transfusion reaction. Another sort of last-ditch approach could be if the patient is male and you knew they had never been transfused before, you could give them Rh positive blood. If they haven't been pre-sensitized, they won't get a transfusion reaction. Although, of course, you have just pre-sensitized the patient if you do this. In any event, these will be extremely unusual cases where you would want to entertain doing something like this. I think it can safely be said that a woman of childbearing age who's Rh negative should never get Rh positive blood. Okay, with that as a background, let's now talk about some of the blood products that are available to us. By far the most common blood product that we use is packed red blood cells. This product is made by the blood bank by centrifuging the donated unit of blood. And after this process, the majority of the plasma is removed as well as the majority of the platelets. You then end up with a concentrated suspension of red blood cells. These cells are then mixed in a preservative solution, and so we finally end up with a unit of blood consisting of 300 cc's of volume with a hematocrit somewhere between 55 to 65%. These packed cells can sit on the shelf for a long time. They have a shelf life of approximately 42 days. And every unit of packed cells should raise the hemoglobin by 1 gram or the hematocrit by 3%. Each unit of packed red blood cells undergoes a washing process as well. This simply means that the cells are passed through a filter that's designed to remove the vast majority of the remaining white cells and platelets. It's platelets and white cells that are responsible for the febrile and hypersensitivity reactions that are sometimes seen after transfusion. And so removing these routinely now has greatly reduced the incidence of these complications. Platelets are also associated with post-op bacterial infections and may be associated with multi-organ failure as well. And so there's some suggestion that there may be less incidence of these problems nowadays because of the routine washing process. There are a few limitations to packed red blood cell transfusions that we should be aware of. Although the preservative solutions get better and better, they are not perfect by any means. And so cells that have been sitting in a blood bank for a period of time all have a decreased oxygen carrying capacity. This is due to reduced ATP and reduced 2,3-diphosphoglycerate in these preserved cells. In addition, The unit of blood will become progressively more acidotic as cells lyse, and so one has to be cautious that they may well be transfusing increased lactate, increased potassium, and increased ammonia with each unit. Platelets are another product that our patients will require from time to time. A platelet transfusion is a pooled product that comes from multiple donors, so platelet transfusions increase infection risk. Each unit is 50 mLs, and each unit of platelets will raise the platelet count by about 10,000. And so we never just transfuse one unit of platelets. They're usually ordered as a six-pack, where we would expect the platelet count to rise by 50 to 60,000. ABO matching is generally done, but is not essential since platelets do not carry ABO antigens. There are a couple of issues with platelet transfusions. The first is that they're highly immunogenic, and so patients can develop antiplatelet antibodies fairly quickly. And if patients require multiple platelet transfusions at different times, it can be harder and harder to find compatible units for them. The other issue is that platelets have a very short shelf life. They only last for about 5 days, and so it's always a challenge for blood banks to have adequate supplies of platelets. The plasma from each donated unit of blood must be frozen within 6 hours of collection. This is necessary to preserve the function of factors 5 and 8, which are sometimes referred to as the labile factors. Each unit of FFP comes in a volume of 225 mLs. ABO compatibility must be ensured, but RH type and cross-massing is not required. FFP has one use case, and that's to provide clotting factors. It's tempting, but completely wrong, to use FFP as a volume expander. Cryoprecipitate is made by thawing FFP and collecting the white precipitate that floats on top. This is another pooled product that comes from multiple donors. And each unit is only 15 mLs. Cryoprecipitate is very rich in fibrinogen and factors 8, 13, and von Willebrand's factor. The main use of this product is in replacing fibrinogen in patients who are undergoing DIC. Virtually all the coagulation factors are now available individually as a recombinant DNA product. This has been particularly valuable in the hemophiliac population, since these patients no longer have to rely on pooled products for their clotting factors. Another very important product is prothrombin complex concentrate. This contains the 4 vitamin K dependent factors 2, 7, 9, and 10. This product contains a 25 times higher concentration of these factors than a standard unit of FFP. Also contained within this product are protein C and S and some heparin. This product has been extremely valuable in the emergency setting where a patient comes in fully or overly anticoagulated on Coumadin and requires an emergency surgery or emergency reversal in a trauma setting. Let's now talk about some of the indications for these blood products. The most common blood product that we transfuse by far is packed red blood cells. The indication for this transfusion is always anemia, either acute or chronic in nature. Anemia, of course, reduces oxygen delivery to the tissues. Now, the decision to transfuse a patient or not is in no way a simple one. There's certainly no magic number of hemoglobin that we can universally rely on. Certainly, as the hemoglobin gets close to 7, we're going to want to be asking the question as to whether our patient might benefit from a transfusion. But the reality is many patients can tolerate a hemoglobin much lower than 7. If they are capable of increasing their cardiac output by increasing their heart rate and their stroke volume, then they'll be well compensated and may not need a transfusion at all. In addition, we have a very large reserve in oxygen delivery capability. The left atrial blood has a saturation of about 95% on average. When that blood returns to the right atrium, the saturation is dropped to about 70%. So we've extracted about 25% of our oxygen at the tissue level. In times of need, that percentage of extraction can be increased. Now, this is all true for a healthy patient. Many of our patients are critically ill. They have impaired compensatory mechanisms, and they have other comorbidities like coronary artery disease or COPD. And so for them, they may well need a transfusion at a number potentially closer to 10 than 7. As surgeons, one thing we need to be aware of is that postoperative mortality increases when the hemoglobin drops below 7. We also need to understand that it's never been demonstrated that correcting this anemia improves this lowered mortality rate. And so it begs the question as to whether the anemia is the cause of the increased mortality or whether it's simply a marker for some hidden variable that we haven't recognized. One clear-cut indication for red blood cell transfusions are in a bleeding patient. Bleeding patients need two things. They need blood and they need their bleeding stopped. While we're waiting for blood, giving a liter of crystalloid is appropriate, but we don't want to flood our patients with too much volume. If it's going to take a long time to get type and cross-match blood, then give them O-negative blood. If they're massively hemorrhaging, then they need FFP and platelets in addition to the blood, and this will be given in a 1:1:1 ratio. Do not worry about their admitting hemoglobin value. The trauma patient who comes in with an open book pelvic fracture may have a hemoglobin of 11, but that 11 is on the way to 4. Just start giving them blood. The other thing we've learned over the years is that we don't need to transfuse to a specific systolic blood pressure. In other words, there's nothing magic about 90 to 100 systolic. If the patient is mentating and making some urine and their blood pressure is only in the 60s, that's sufficient for the time being. They're tolerating it. Of course, they will need their bleeding stopped, and that's what we will have to turn our attention to as surgeons. Another straightforward indication for transfusion is in a symptomatic patient. We may have a patient who's showing evidence of myocardial ischemia, whether that's by elevated troponins or whether it's by EKG changes or new onset arrhythmias. We may have a patient who's oliguric, or they may be exhibiting mental status changes. They may have an elevated lactate level. If they have a hemoglobin less than 10, it's certainly reasonable to transfuse these patients. Now, it's quite possible that these symptoms they're exhibiting are related to things other than anemia, but taking anemia out of the equation is going to be important to getting at any other root cause that may be involved. A less clear-cut case is what to do with a patient who has a hemoglobin between 7 and 8. Now, it's true that most patients with a hemoglobin below 7 will require a transfusion, but not all. And it's also true that many patients with a hemoglobin of 8 or above will not need a transfusion, but not all of them either. And so this hemoglobin between 7 and 8 is really a gray area. As physicians, we're always trying to find the balance between risk and benefit. And the risks of anemia are real, and we don't want to expose our patients to those risks unnecessarily. But the risks of transfusion are also real, and so we don't want to just transfuse everyone unless they have a very clear-cut indication. But I think in most circumstances, in a postoperative patient who has a hemoglobin in the 7 to 8 range, I really do think that most of them will benefit from a transfusion. The indications for fresh frozen plasma transfusions are relatively straightforward. The most common circumstance would be a patient who presents who needs an emergency operation and who's found to have an elevated INR on pre-op testing. This elevated INR may be on the basis of liver disease, or it may be on the basis of anticoagulants they're taking. But in any event, this INR would have to be corrected with fresh frozen plasma before they can safely go to surgery. Another circumstance where FFP is required is in the massive transfusion protocol. Patients who are massively bleeding are also losing plasma, and they're losing clotting factors, and so these important clotting factors need to be replaced in addition to the red cells. Platelets also have to be replaced at the same time. There are several indications for platelet transfusions. I think there'd be general agreement among surgeons that any patient with a platelet count less than 10,000 should be given platelets to prevent any spontaneous bleeding episodes. In a patient who's already bleeding, I believe most of us would give platelets for a platelet count less than 30 to 50,000. In head injury patients, the transfusion trigger is usually higher, maybe upwards of close to 100,000. Platelets are also given as part of the massive transfusion protocol. And there are occasions when we would give platelets even though the platelet count is normal. Uremic patients will usually have a normal platelet count, but their platelets don't work very well. Likewise, a patient who is on Plavix for stent prophylaxis may well need platelets also if we're contemplating doing an invasive procedure or if they're actively bleeding. Blood transfusions are clearly life-saving in appropriately chosen patients. But like any complicated medical treatment, transfusions have their own inherent risks and complications. By far the most feared transfusion-related complication is the acute hemolytic reaction. This is estimated to occur in anywhere from 1 in 38,000 to 1 in 70,000 transfusions. And about 44% of these events prove to be fatal. The error is always the same. It's the transfusion of ABO and/or RH incompatible blood to a patient. And when a root cause analysis is done of this complication, it always points back to human error. The transfusion of incorrectly typed blood into our patients leads to the immediate intravascular destruction of these red cells. This ends up resulting in the liberation of free hemoglobin into the circulation. This results in two problems for our patients. The first is that this hemoglobin is prone to precipitating in kidney tubules, which can lead to acute tubular necrosis and acute renal failure. The second problem is the more lethal complication. Free hemoglobin is recognized by the immune system as a damage-associated molecule. And so we end up with wide activation of the clotting cascade and the complement cascade. This ultimately can result in disseminated intravascular coagulation, which will be the terminal event in these patients. The clinical presentation of a transfusion reaction is going to depend very much on whether the patient can communicate with us. If the patient is awake and alert, then they're likely to complain of immediate heat or pain along the vein in which the blood is going into. They're also likely to complain of facial flushing or chest and/or lumbar pain. Fever, chills, and shortness of breath generally would follow a little later on. In a patient who's in the ICU, who may well be intubated and sedated, oliguria temporally related to a transfusion might be the tip-off. In the operating room, where our patients are generally anesthetized, a major clue to this problem may be diffuse DIC-type bleeding and unexplained hypotension. The diagnosis of an acute transfusion reaction can often be made quite quickly at bedside. A Foley catheter should be inserted if one is not already present, and the urine can be evaluated for color as well as volume. The clinching test, however, is the urine dipstick. If hemoglobin is present, then that's enough evidence to begin treatment. Of course, blood should be sent for a haptoglobin and a Coombs test, and the patient needs to be retyped and crossed. In addition, the suspected unit of blood needs to go back to the blood bank, and it needs to be retested also. For a patient with a suspected acute transfusion reaction, the first step, of course, is to stop the transfusion. This will usually have been done by the nurse attending to the patient. The second step is to try to prevent precipitation of hemoglobin in the kidney tubules. And so the patient is generally going to be aggressively hydrated with normal saline, and then a diuresis will be instituted with mannitol and Lasix. Some ICU doctors also recommending giving the patient bicarb. The goal here is to alkalize the urine, which may help prevent precipitation in the kidney tubules. If the patient becomes anuric or becomes hyperkalemic, they may well need dialysis. And lastly, attention will have to be given to DIC if the patient develops this problem. They'll need to be treated with FFP, cryoprecipitate, and platelets as necessary. A delayed transfusion reaction is a much less serious problem. In fact, it may not even be noticed. It generally will occur 2 to 10 days after the transfusion, and if the patient is in the hospital and getting labs drawn, a mild anemia and a mild indirect hyperbilirubinemia may well be noticed. The patients in general will be asymptomatic. A delayed reaction results from non-ABO incompatibilities. In other words, the patient is reacting to one of the minor transfusion antigens. Febrile reactions are a much less frequent problem nowadays, since red cells are now routinely washed. This washing process filters out donor white blood cells. The febrile reaction results from patient antibodies against donor HLA antigens that exist on white blood cells. If you get a call about a patient who's developed a fever 30 to 60 minutes after a transfusion, I strongly suggest you go see the patient. Most of these patients will look just fine, and if so, you do not have to stop the transfusion. They can be treated with Tylenol for comfort. Some patients are known to develop frequent febrile reactions, and these patients can even be pre-medicated with Tylenol. Overall, allergic reactions are pretty uncommon, but when they do occur, they're usually associated with platelet transfusions or FFP transfusions. Most patients will have mild symptoms. They may break out in hives or develop a rash. They'll complain of itching and sometimes flushing as well. True anaphylactic shock is extremely rare. The reaction is caused by preformed patient antibodies, usually against platelet-associated antigens. As always, go see the patient. Most of these patients will be just fine, and their symptoms can be treated with Benadryl. Usually there's no reason to stop the transfusion. If the patient is having some respiratory distress or is audibly wheezing, then of course the transfusion should be stopped. These patients may well also need to be treated with hydrocortisone or sometimes even epinephrine. Disease transmission is always going to be a concern with any transfusion product. Fortunately, the blood supply in 2021 is probably as safe as it's ever been, but still, it's not completely safe. HIV and hepatitis C occur approximately once per every million units transfused. Hepatitis B is a little bit more frequent at one transmission per every 300,000 units transfused. CMV is always going to be a concern with immunosuppressed patients. In different parts of the world, different diseases are more common, and they can be transfused through blood as well. Malaria and Chagas diseases are examples of this. And there's always going to be new pathogens that evolve and use blood as a wonderful transmission vector. We're already seeing incidents of West Nile virus and Zika virus being transmitted through the blood supply. Another very serious complication is transfusion-related acute lung injury, or TRALI. This is defined as a new acute lung injury that occurs within 6 hours of transfusion. Basically, these patients develop an ARDS type picture with acute non-cardiogenic pulmonary edema. They'll have diffuse bilateral infiltrates on X-ray, and they may well have a fever. The pathogenesis has been related to donor and recipient HLA and neutrophil antibodies. The management here is largely supportive. Stop the transfusion, and many of these patients will require mechanical ventilation. Each unit of packed red cells consists of about 300 cc's of volume. And some of our patients are going to have trouble handling this volume, especially if they need to receive multiple units of blood. Some strategies for dealing with this are to give Lasix in between each unit of blood. And if it's a dialysis patient, giving the blood in the dialysis lab is often the best way to do it, because then you can also remove excess volume at the same time. There is a clear correlation between red blood cell transfusion and postoperative immunosuppression. Surgical patients who've been transfused have increased postoperative morbidity and mortality and increased susceptibility to bacterial infection. From a cancer standpoint, the transfusion is correlated with increased cancer-related mortality and decreased disease-free survival. However, in the transplant world, transfusion is related to improved outcomes in kidney transplants. There are less acute and chronic rejection episodes. Although the correlation is clear between transfusion and immunosuppression, causation has never been proven. One proposed etiology for the immunosuppression is cytokine release related to the transfusion of donor white blood cells. The last transfusion-related complication we'll talk about has to do with the way blood is preserved and stored. If a patient gets a massive transfusion, let's say 6 or more units of packed cells, they're also getting a large citrate load. This citrate toxicity can lead to hypocalcemia as well as metabolic alkalosis. In addition, blood can sit on the shelf for up to 42 days, but as time goes on, some of these cells will lyse, so older blood can be plagued with a high potassium load, which can result in clinical hyperkalemia if multiple units are transfused. Since blood is a scarce resource, it's expensive, and it's associated with multiple complications, it's reasonable to end this discussion by considering some alternatives to transfusion. One alternative to using banked blood is to pre-donate a unit of your own blood for use in your own elective surgical procedure. This is most commonly done in orthopedics, in particular operations like hip replacement, which have a very long lead time. In other words, they're often scheduled many months in advance, and this allows a patient time to do the pre-donation. We typically don't see this in general surgery at all, since most of our surgeries only have a couple of weeks lead time before they get done. There are some contraindications to pre-donating blood. You need to have a reasonable hemoglobin, which here is defined as greater than 11, and you can't have any significant cardiac disease. It is really important to remember that the pre-donation process does not eliminate the human error that might occur during the collection or transfusion process. Another variation on this theme would be to have a relative donate a unit of blood for you to use. As a practical matter, this turns out not to be safer than donor blood. The only real use case for this type of donation is in family kindreds that have very rare blood types. The use of cell saver devices is very common in cardiac and open vascular surgery. These devices allow blood to be collected from the operative field and then washed in a filtering system. The blood can then be given right back to the patient without the blood ever having to leave the operating room. This technique has never particularly caught on in general surgery, presumably because many of our patients will have ascites or cancers or even emergencies like perforated bowels. But the reality is these are only relative contraindications. They're not absolute contraindications because the cell saver devices do have terrific filtering capabilities. If you have a patient in the emergency room with a massive hemothorax, give some thought to using one of the Pleurovacs that have a detachable collection chamber. This chamber allows you to give the patient's blood right back to them, so it serves as an auto transfusion type device as well. There are a number of drugs available to us that will help limit our use of banked blood. Tranexamic acid is a drug that's proven to be very useful in the trauma setting. It inhibits fibrinolysis, and so it's very similar chemically to aminocaproic acid, or Amicar, but is more potent. The CRASH-2 trial clearly demonstrated decreased mortality if this drug is given within 3 hours of injury. Another useful drug is erythropoietin. This drug increases red blood cell production in the bone marrow. So it's not to be used in emergency situations, but it can be used in urgent to elective type cases. One real advantage of this drug is that it's acceptable to most Jehovah's Witnesses. Oral iron is commonly prescribed for chronic iron deficiency anemia. Iron can also be used IV, and it will rapidly raise the hemoglobin, but it does carry a very real risk of severe allergic reactions, making it less useful. DDAVP causes release of factor VIII and von Willebrand's factor from endothelial cells. The most common time we would use this drug is if we're operating on a patient with kidney failure who has platelet dysfunction from their uremia. DDAVP will also be useful, of course, in patients with von Willebrand's disease and in those patients with the milder version of hemophilia. Okay, that's it for this week. Next week, we'll move on and talk about hemostasis and coagulation. For those of you who are interested, this website contains a written version of everything we talk about in these videos.